Dear all, here is our last lecture discussing my book, Nephrotube Synopsis of Conventional Hemodialysis, first edition. In this lecture, we will discuss chapter 12, the venous catheter complications regarding their diagnosis and management. Before I start, I want to mention that in this chapter, I sometimes use the terminology venous catheters and sometimes the terminology central venous catheters. Both are the same, but sometimes I use this and sometimes this according to how they are mentioned in the original reference. In the description of this video in YouTube, below the video, we'll find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. We'll find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. We'll find link to download this book for free. We'll find link to download the PDF of this lecture for free if you like to use it. You will find the link for my website Nephrotube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to Nephrotube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of Nephrotube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. This is my talk outline. I will cover venous catheter infections, thrombosis, dysfunction of the venous catheter, and finally central venous stenosis. Starting by venous catheter infections, I will start by exit site infection. This is the exit site of the catheter. In exit site infection, you will find local manifestations like this, where there will be hyperemia, induration, and or tenderness. But one of the most important, or the main most important point to discuss to diagnose exit site infection, that these local signs are only 2 centimeters or less from the exit site. This is the exit site, and the induration, redness, hyperemia are only less than 2 centimeters from the exit site. Also, there may be drainage or pus outside the exit site. These are the local manifestations of exit site infection, but it may be also associated with systemic manifestations in some patients. Regarding diagnosis, these local symptoms are enough for diagnosis, but if there is any drainage out from the exit site, this drainage must be collected and sent for culture and sensitivity. How to treat exit site infection? For sure, the treatment is antibiotic therapy, topical and oral. The oral antibiotic should cover positive organisms, and the duration of treatment ranges from 7 to 14 days according to the isolated organism and your local practice. Also, it is important that the patient should be investigated for nasal carriage of Staphylococcus, and if it is positive, then the use of intranasal miprocin cream for prophylaxis to eliminate the nasal Staphylococcus is important to prevent further exit site infections. Should I remove the catheter if there is exit site infection? Yes, there are indications for catheter removal if exit site infection is associated with one of the following. First, if there is any systemic signs of infection as leukocytosis and fever, if pus expressed from the track of the catheter, if blood cultures turned positive, if there is systemic manifestations with these patients, you have to make blood cultures. If blood cultures are positive, you have to remove the catheter. And finally, if the infection is resistant to treatment or the infection is recurrent after initial course of antibiotics, you should remove the catheter. Regarding prevention of exit site infection, we mentioned in the previous lecture regarding the venous catheter care. To prevent infection in general, a good exit site care must be taken, and the use of skin antimicrobial ointments may be used, as we mentioned before in the previous lecture. Regarding the second type of infection that can occur as a complication for venous catheters is tunnel infection. What are the manifestations of tunnel infection? They are the same as exit site, but the local symptoms and signs here extends more than 2 centimeters from the exit site. This is the exit site. You can find that the tenderness and the hyperemia and induration are extended to more than 2 centimeters from the exit site along the subcutaneous tunnel. How to diagnose? Local signs and symptoms are enough for diagnosis, but again, if there is drainage, as this photo, this drainage must be collected for culture and sensitivity. How to treat tunnel infection? First, catheter removal is the main treatment, and the new catheter should be inserted at another site. Antibiotic therapy start by broad spectrum antibiotics to cover both gram-positive and gram-negative organisms, and then modify the antibiotics according to culture and sensitivity. The duration here, if the patient has only tunnel infection without evidence of catheter-related bloodstream infection, and I will talk about catheter-related bloodstream infection in the coming slides. If it is only tunnel infection, the duration of the treatment should be 10 to 14 days. But if the patient has catheter-related bloodstream infection with the tunnel infection, the duration of therapy will be determined by the management of CRBSI, as I will mention later. Then, the most important item in my lecture is catheter-related bloodstream infection. First, what are the manifestations of catheter-related bloodstream infections? It depends on the severity of the case. Milder cases, there will be fever. In severe cases, there may be hemodynamic instability. Some patients catch only symptoms on dialysis. This suggests that there is, during dialysis, that there is systemic release of bacteria and or toxin from the catheter. During hemodialysis, you will find your patient has fever, has shivering on dialysis. There may be metastatic infections, and this is very important. This is a very important point to put in mind. Metastatic infections as endocarditis, osteomyelitis, epidural abscess, and septic arthritis. This is important because you have to know that these metastatic infections may not be immediately apparent at the onset of CRBSI diagnosis. They can first manifest clinically within weeks or months after the initial bacteremia event. So you have to put this in mind in any patients with CRBSI, that metastatic infections may appear after weeks or months after even the remission of the CRBSI. The main causative organism in catheter-related bloodstream infection is gram-negative positive organisms, although in some cases gram-negative infection may occur, but in minor cases. How to diagnose catheter-related bloodstream infection? First, you have to get samples for culture. You have to get blood samples and catheter samples for blood culture and catheter culture. For blood, you have to get blood from the peripheral veins of the patient, and if the patient has poor veins, you can get blood from the dialysis circuit. Regarding the catheter, you have to take blood culture from the catheter hub, and if you remove the catheter, you have to culture the distal 5 centimeter of its tip. So you will have one blood culture from the patient himself or from the dialysis catheter, one of them, and one culture from the hub of the catheter, plus or minus the culture of the catheter tip if you remove the catheter. When CRBSI is confirmed and when CRBSI is unlikely. CRBSI is confirmed if there is absence of other apparent source of infection, and there is isolated same organism regarding species and sensitivity, species and antibiogram from all cultures. You have to find same organism from the culture of the peripheral source and the catheter hub blood culture if catheter is removed, if the catheter is not removed, and you have the same organism in the peripheral source blood culture and the catheter tip culture if the catheter is removed. And some data, if available, can support the diagnosis. If there is a simultaneous quantitative culture showing that the ratio between the catheter tip or hub culture to the peripheral source blood culture is equal to or more than 3:1, this is supported for CRBSI. If it is more than 3:1, this means that the quantity of the bacteria or the causative organism in the catheter culture is more than that in the blood culture in the ratio 3:1, and this is logic because the catheter is the main source of the infection. Also, if the microbiology unit told you the differential time to positivity, that the catheter cultures, whatever the tip or hub blood culture, showed positive organisms 2 hours before the peripheral blood culture. This supports CRBSI. If the bacteria or the causative organisms grow in the blood culture, in the catheter cultures before the bacteria or the causative organism showed in the peripheral source blood culture, this indicates that the catheter is the source of infection. CRBSI is unlikely if both the blood culture and the catheter cultures are negative, but the care there may be a possibility of contamination or colonization. This can be suspected if there is negative blood culture, but there is a positive catheter hub or tip culture. And by the way, sometimes you also may find in contamination. In the case of contamination, you can also find positive blood culture and positive catheter culture because of contamination. So what are the difference between contamination and catheter colonization and how to treat? Contamination, this is because the culture samples, the blood samples, are not taken under aseptic technique. It is important, according to ETSA, to use a aseptic technique to avoid contamination of the culture. Regarding contamination, it is common if you found that negative blood culture and the positive catheter culture. In this case, removal of the catheter is feasible. But if you don't remove the catheter, you have to put in mind that subsequent development of CRBSI is an option, and you have to follow your patient closely for clinical manifestations of CRBSI. Also, if the patient had multiple positive catheter cultures, especially that grow coagulase negative staphylococcus, Staphylococci or gram-negative bacilli, but the blood cultures are negative, then antibiotic therapy without systemic antibiotic therapy for 10 to 14 days is important, especially when you leave the catheter in place. Let's talk in more details about catheter-related bloodstream infection. How to treat, how to manage. Before I talk about management of catheter-related bloodstream infection, I want to mention that the following steps and the following stepwise approach that I will mention for CRBSI management is mainly applied for long-term tunneled cuffed catheters. However, some units use the same approach for the short non-tunneled uncuffed catheters. Although the main line of treatment of infected short-term non-tunneled uncuffed catheters is catheter removal. However, some units, as I mentioned, use the same approach used for long-term cuffed catheters to manage the short-term infected catheters, especially in patients with previous access. How to manage? First, we have to check if there is severe sepsis in the patient, suppurative thrombophlebitis, or metastatic infections. Also, we have to check culture results if there is any organism of these organisms. The answer is yes or no. If no, there is no one of these complications and there is no one of these organisms in the culture, then we will go through what is called catheter salvage pathway, and I will talk about it within minutes. After catheter salvage, there is another pathway I will mention in details later about surveillance. Then a pathway about catheter removal. From the start, if there is one of these complications or one of these organisms in the culture, you have to ask yourself, is there another vascular access for the patient? Is there exit site or tunnel infection? If no, there is, if yes, there is another vascular access for the patient, and if there is exit site or tunnel infection, you have to remove the catheter. If no, we can try a pathway called exchange on guide wire. From it, we will go to surveillance pathway. Let's take each pathway of them and talk about it. First, I will start by salvage pathway. In salvage pathway, you will keep the catheter in its place. We'll start empirical antibiotics and antibiotic lock therapy. I will mention these details now. Then you have to assess the patient after 2 to 3 days regarding clinical response, fever, and laboratory response regarding the leukocyte count and CRP. If there is improving or not. If not improving, you have to remove the catheter. If there is improving, continue antibiotics, then go to the surveillance pathway. What are the empirical antibiotics that I have to start in these patients? First, you have, again, I have to mention that you have obtain appropriate cultures before initiating these empiric antibiotics for treatment. Okay, and then you change the antibiotics according to the culture sensitivities. First, the protocol is to use vancomycin to cover gram-positive bacteria, including MRSA. An important point here, you can use alternative to vancomycin in 2 situations. First situation, if the patient is documented to have vancomycin allergy, or there is documentation that this patient has vancomycin-resistant enterococci before, which is called VRSA. So it is logic not to start with vancomycin. You can replace it with daptomycin. Another situation, if the prevalence of MRSA is low in your area and unit, you can replace vancomycin with cefazolin. In protocol 1, you will use vancomycin with 1 empirical gram-negative antibiotic based on your local antibiogram, or you can use one of these: ceftazidime, carbapinam, and or piperacillin tazobactam. Regarding the second protocol, you can use vancomycin plus gentamicin or topramycin, and the same precautions regarding the vancomycin and its other substitutes as in protocol 1. We have two specific situations. Special situation protocol is to cover multi-drug resistant bacteria. You have to use vancomycin and 2 antibiotics covering gram-negative, not 1. In protocol 1, we use only 1 gram-negative covering antibiotic. Here you have to use 2. So when to suspect that this patient may have multi-drug resistant bacteria, in cases with isolated multi-drug resistant bacteria as Pseudomonas aeruginosa, this is suspected in neutropenic patients, severely ill patients with sepsis, and in patients known to colonize these pathogens in previous cultures. Another special situation is to cover Candida by antifungal, and antifungal treatment should be added if the patient is on total parenteral nutrition, the patient had prolonged use of broad-spectrum antibiotics, in hematological malignancies, recipient of bone marrow or organ transplant, in femoral catheterization, the fungal infection is common, and if the patient has colonization of Candida from other multiple sites from his body. So these are the protocols we have to use as empiric therapy for management of CRBSI. Regarding the doses, I put the different doses according to the GFR of the patient. I mean that these patients are on hemodialysis. You can check them, and I put the doses if there is difference between high flux and low flux dialyzers use. But what I mentioned, I will not read these, but what I want to mention that in vancomycin, gentamicin, topramycin, the better is to have pre-dialysis trough drug level to avoid toxicity from these drugs. But usually this not done practically actually. The question now, for how long should I give the antibiotic? It depends on the isolated organism. If the patient has Staphylococcus aureus, the antibiotic treatment will be continued for 4 weeks. Coagulase negative Staphylococcus for 2 weeks. Gram-negative bacilli for 2 weeks. Candida, you have to continue antifungal treatment for 2 weeks after the first negative blood culture. So you have to repeat your blood culture. Once it is negative, you have to continue antibiotics for 2 weeks after this negative blood culture. Back to the catheter salvage pathway, we now mentioned and discussed how to start empiric antibiotics. Now, what about the antibiotic lock therapy? Antibiotic lock solution is mainly designed to kill bacteria present in biofilm. We know that a biofilm can be formed around the catheter, especially the tip, and this biofilm may be a place where bacteria can hide. So we have to use antibiotic lock in these cases. The content of antibiotic lock is different from one unit to other. A lot of protocols are available online. Please refer to your local unit to know the empiric antibiotic lock used in your unit. And once you get the culture and sensitivity results, you can change the antibiotic in the antibiotic lock according to the sensitivities of the culture. Regarding the dwell time of antibiotic, it is generally better to not exceed 48 hours. So in hemodialysis patient, it is logic to renew it after dialysis session. But if the patient has a femoral catheter, the dwell time must be only 24 hours. So we have to change the antibiotic lock every 48 hours for subclavian and internal jugular catheters, and for femoral catheters it must be every 24 hours for ambulatory patients with femoral catheters. Duration of antibiotic lock use, you have to use the antibiotic lock through the duration of the systemic antibiotics. For example, we mentioned in the previous slide that you will treat Staphylococcus aureus for 4 weeks. So we have to use antibiotic lock for 4 weeks and so on. Back to main stepwise approach. We discussed now catheter salvage and its lines of management. What about exchange on guide wire? What about this pathway that we will use if there is other access, vascular access, and there is no exit site or tunnel infection? Sorry, if we will use it if there is no another vascular access and there is no exit site or tunnel infection. So again, I have to mention and stress on this point that exchange on guide wire can be done only in absence of exit site or tunnel infection. You will start as you started in patients with salvage pathway, antibiotics, and you maybe also use antibiotic lock. Reassess after 2 to 3 days by clinical and lab measures and see if the patient is improving or not. If not, so remove the catheter. If yes, you can now exchange the catheter on guide wire. Then continue antibiotics till that you get the culture results, and finally you will go to the surveillance pathway. Regarding the surveillance pathway, what we have to do in these 2 cases, pathway 1 and pathway 2, there is a catheter left in place. You have to follow these catheters by new cultures. First, you have to obtain 2 sets of blood cultures 72 hours after the initiation of appropriate therapy. And if they still positive, you have to remove the catheter. The second, you must have a 1 week culture after completion of appropriate therapy, after finishing the antibiotic course. And if it's still positive, you have to remove the catheter also. Okay, finally, regarding the catheter removal pathway, when you remove the catheter, don't forget to culture the tip, the distal 5 cm of the catheter. Then you will continue your antibiotics, as we mentioned in the salvage pathway. And you will ask yourself, is the patient in need for urgent dialysis? If yes, please insert temporary non-tunneled catheter in another site. After this, or if the patient is not in need for urgent dialysis, you have to continue antibiotics. And if the patient is still feverish, after 72 hours, you have to obtain new cultures. And if there is persistent bacteremia after 72 hours, or fungemia, and persistent fever after appropriate antibiotic, you have to do transesophageal echo for this patient. And start and continue antibiotics for 4 to 6 weeks. So if there is improvement in the patient situation after you removed the catheter and you started appropriate treatment, especially if it is on the culture and sensitivity, if there is no improvement within 72 hours, evidenced by fever or persistent bacteremia or fungemia on a culture, you have to do transesophageal echo, not transthoracic echo. Transesophageal to exclude endocarditis. Transthoracic is not sensitive in our cases. And you have to continue antibiotics for 4 to 6 weeks. When to reinsert long-term catheter in the patients, you have to reinsert catheters only if the patient is afebrile for 48 to 72 hours. And CRP is normal, but I have to stress on this point that usually in our dialysis patients, the CRB is never being normal because CRB is an inflammatory marker So it will never turn to normal even in patients without infection. But if it is in a lower titer in absence of other signs of infection and normal leukocyte count, then we may consider that the infection is resolved. And finally, it's better to redo the blood cultures before reinserting long-term catheter to be sure that they are negative. Regarding the transesophageal endoscopic echo, what are the indications? Is it only the persistence of fever and bacteremia after the removal of the catheter? No, we have multiple indications to do transesophageal endoscopic echocardiography in our patients. The first, as we mentioned now, persistent bacteremia or fungemia or persistent fever 72 hours after start antibiotic treatment catheter removal. But you have to do transesophageal echo also in any case of Staphylococcus aureus and in patients with who have CRBSI, and these patients also have prosthetic heart valve, in patients with pacemakers, and in patients with defibrillators. Back to our general approach, what about metastatic complications? If the patient has systemic complications, metastatic complications, what is the recommended duration of therapy? In patients with suppurative thrombophlebitis, continue antibiotics for 4 to 6 weeks. With endocarditis, continue antibiotics for also 4 to 6 weeks. Osteomyelitis, antibiotics for 6 to 8 weeks. If there is spinal epidural abscess, and this will present by fever, backache, spinal tenderness, and maybe neurological manifestations and as leg pain weakness, sphincter dysfunction, and maybe paralysis. And this is diagnosed mainly by CT myelography, and it is better than MRI. In these cases, early immediate decompressive surgery is advised, although some patients rarely may respond to antibiotics. The main and important point is how to prevent catheter-related bloodstream infection. The first point is to stick to the aseptic techniques, as we mentioned in the previous chapter, while inserting, connecting, or disconnecting the catheter. Also, as we mentioned in the previous lecture, there may be a rule for antibiotic antimicrobial lock or once week TPA lock in patients with high risk of CRBSI and in facilities with high rates of CRBSI. And finally, Kiduki vascular access guideline in their 2019 update considered that it may be reasonable to use an antimicrobial barrier cap to reduce CRBSI according to the clinical judgment and the availability in your unit. Now we'll talk about the second complication, which is vascular catheter thrombosis. We finished the infections, we'll talk about thrombosis, and the first and most important one is intraluminal thrombosis. Regarding intraluminal thrombosis, you will find the catheter is blocked. You cannot push saline in it, and you cannot aspirate blood from it. How to manage intraluminal thrombosis? According to Kiduki 2019 update, they recommended alteplase or urokinase plus citrate for restoring blood flow in included catheters. And I will talk about the recommended dose for alteplase now. Also, they recommended the use of the push-pause or dual method techniques. So you have to put the alteplase in the catheter by the push-pause method or dual method, and I will discuss both of them now in details. Some references mention that if the dual method failed, and for sure, if the push-pause method failed, you can use, if both of them failed, you can use the infusion method. But actually, the infusion method is very difficult, sophisticated, and has a lot of complications. Finally, Mechanical brushing of thrombus is an option, but actually it is not that popular. Let's talk what is push-pause method, what is dwell method, and how to use. We have push-pause method, overnight dwell, and short dwell. The overnight dwell method is the long dwell method. Let's start by this. First, instill alteplase in each lumen of the catheter venous, the central venous catheter. The recommended use dose of alteplase, according to Kiduki 2019 updates, they suggest 2 mg of alteplase in preference to 1 mg, although the British Renal Hemodialysis Committee in 2021 suggests the use of 1 mg of alteplase. So whatever the method you will use, instill the alteplase in each lumen, then instill normal saline to fill the internal lumen with an overfill of 0.2 ml. If you instilled alteplase in only one lumen, because you know that only one lumen and you are sure that only one lumen of the catheter which is thrombosed, so we have to lock the other lumen with anticoagulant lock. Then wait 10 minutes and then gently push normal saline into lumen. Use 0.3 ml saline in large volume catheters with volume greater than 1.5 ml, and only 0.2 ml of low volume, 0.2 ml of saline for low volume catheters, and then wait 10 minutes. Then repeat this step once more. So you have to put alteplase, wait 10 minutes, push saline, wait 10 minutes, push saline again, then wait 10 minutes again, and try to aspirate clots by 10 ml syringe and discard. And if you are unable to aspirate clots, you can push remaining alteplase through the catheter lumen, and when it is free, the catheter is free, you can push in it saline, forcefully flush the lumen with normal saline to clear it. Another method is overnight dwell method. The first step is the same as push-pause method. Then you will leave alteplase. So you will instill alteplase in each lumen or in one lumen and leave alteplase till the next hemodialysis visit. Once the patient reached the hemodialysis unit, aspirate alteplase immediately. If unable to withdraw, then push remaining alteplase and push saline if the catheter is full. Regarding short dwell time, the first step is the same as overnight dwell method and push-pause method, but this time we will only leave the alteplase in situ in the catheter for 30 to 60 minutes, and then try to aspirate. If no response, you have to push. But for sure, the longer dwell time, which is the overnight dwell time, is better than the short dwell method. I think it is, from my point of view, if you have thrombosed catheter, you start by push-pause method. If no response, you can try one of these according to your opinion. So how to prevent the occurrence of intraluminal thrombosis? First, it is very common to have clots at the tip of the catheter. If I draw the catheter here, this is the continuation of the catheter inside the patient's vascular system. You can have clots at the tip of the catheter here, and this may result from poor catheter care, because at the end of treatment, care must be taken while locking the catheter by anticoagulation block, the anticoagulants, to prevent backflow of blood to the tip of the catheter. This can be done by clamping the catheter here, while the syringe is still pushing the antibiotic lock in with enough pressure to prevent the entry backflow of blood into the catheter tip. Regarding the use of systemic anticoagulants or antiplatelets to prevent intraluminal thrombosis, there is no rule for the use of systemic prophylactic anticoagulants, but Kiduki 2019 update mentioned that a low-dose aspirin may be used to maintain tunneled central venous catheter patency in patients with low bleeding risk. Regarding intracardiac thrombosis, just a rapid notice that if the patient has intracardiac thrombi, he will need prolonged systemic anticoagulation, 6 months or longer, and follow up with a cardiologist. And for sure, the thrombus within the catheter may be silent or can give rise to emboli, with embolic events according to the site of these emboli. And now we will cover venous catheter dysfunction, poor catheter flow. What is meant by venous catheter dysfunction or poor catheter flow? This means that there is a failure to maintain blood flow during hemodialysis, which is adequate for hemodialysis without lengthening the dialysis treatment time. There is another definition for venous catheter dysfunction, which is the failure of the catheter to deliver a blood flow rate of 300 ml at least at a pre-plumb pressure less negative than minus 250 millimeter mercury. But actually most of the hemodialysis units have no pre-pump pressure, so it is easier to define poor catheter flow as that mentioned by the Kiduki vascular access guidelines, that there is a failure to maintain adequate blood flow or adequate hemodialysis without lengthening the dialysis treatment. We have two onsets of catheter poor flow: early initial dysfunction immediately after the insertion of the catheter, and late dysfunction. Regarding early dysfunction. Regarding initial early dysfunction, causes may be due to compression of the catheter within the tunnel due to edema of the tunnel, a kink in the catheter due to or acute angle in the tunnel. The catheter is not well inserted with acute kink, improper tip placement, and we mentioned in the previous lecture the proper tip of the catheter. If there is malposition of the catheter is inserted in another veins. If there is intraluminal thrombosis, and we mentioned this in the previous slides. Regarding diagnosis, for sure X-ray, chest X-ray may be valuable, especially if there is a kink, improper tip placement, or if there is malposition of the catheter. How to manage initial early dysfunction of the catheter? First of all, regarding edema of the tunnel, edema usually subsides within 24 hours. If there is kink or malposition, this requires the placement of the catheter again, using a different tunnel or different length of the catheter. And it is important to make the insertion site in the lower part of the neck, near to the clavicle, because high insertion sites in the neck make the catheter moves with the movement of the neck. With the movement of the neck, the tip may move up with neck movement, leading to poor flow. And also, exit site, if it is close to the breast tissue will pull the catheters high to the superior vena cava, causing malposition. And finally, if there is intraluminal thrombosis, you can treat it as we mentioned before. Regarding late dysfunction of catheters, what are the suspected causes? The main important points are fibrin sheath and mural thrombus. I will discuss in details. Mural thrombus means that there is a thrombus in the vessel itself that may occlude the venous catheter. Regarding fibrin sheath may be developed around the catheter, closing its ports and causing catheter dysfunction. The fibrin sheath may develop within a week or two of insertion. And I heard a status before that every central venous catheter has a fibrin sheath that may be silent or symptomatic. This is the shape of fibrin sheath when we remove the catheter. Especially if it is long standing, you will find it formed around the catheter. And this is its shape in the imaging. I will mention the imaging later. We mentioned that fibrin sheath, almost all inserted catheters have fibrin sheath within a week or two. Regarding presentation, as I mentioned, fibrin sheath may be silent or may obstruct the ports of the catheter. And in this case, if fibrin sheath obstructs the catheter port, you will find that aspiration from the catheter is difficult, although saline infusion is easy. This is because the pull valve effect of the fibrin sheath. When you push or infuse saline, this positive pressure of pushing the saline will push the fibrin sheath, and the saline will go into the blood. But when you try to aspirate, you will create a negative pressure that will suck the fibrin sheath around the ports of the catheter, causing difficult suction. Fibrin sheath is dangerous because it's considered as a nidus for bacteria and infection. There is no rule actually for the use of warfarin or systemic anticoagulants on chronic basis to prevent the formation of these fibrin sheaths, and it is diagnosed by radiocontrast material, as I showed you. With the injection of radiocontrast material into the catheter, you can find the fibrin sheath developed around the catheter. Regarding its management is by interventional radiology. A balloon catheter is inserted on a guide wire through the catheter tunnel. Then the balloon catheter is inserted into the lumen of the fibrin sheath itself, then inflated to disrupt this sheath, and we have to confirm disruption of the sheath using radiocontrast injection. So this is the main management of fibrin sheath if you will leave the catheter in place. If there is option to remove the catheter and replace with another catheter, or catheter in another place, it may be also another option for management. Regarding our last point for complications of venous catheters is central venous stenosis. What are the risk factors for central venous stenosis? First, the use of stiff non-silicone catheters, and this is not popular nowadays. The subclavian approach. While using the subclavian approach for inserting central venous catheters, the occurrence of central venous stenosis is very common because of higher angular stress on the catheter in this position. Also, prolonged duration of the catheter is a risk factor for central venous stenosis. Patients with previous catheter-related infections, history of any intravenous apparatus as pacemaker and electronic devices. What are the presentations of central venous stenosis? First, as we mentioned before mentioning what we mentioned before, stenosis may be asymptomatic or may be symptomatic. It may be asymptomatic, and symptoms are unmasked by the creation of a fistula or graft, because when we create AV access, this will cause a high flow through the arm, so this will make the stenosis apparent and symptomatic at this point. The second presentation, venous hypertension, and we mentioned signs of venous hypertension in the lecture of AV axis examination. You can find swelling of the arm, maybe breast, shoulder, neck, and face, and you can find collaterals in the arm also and on the chest. There may be pain in the extremity, skin discoloration, and for sure maybe vascular access dysfunction. Vascular access, if it is created in a patient with central venous stenosis, there may be vascular access dysfunction in the form of multiple high venous pressures on dialysis. You can find that there is also inadequate dialysis, prolonged bleeding after needle removal post-dialysis, and we mentioned before also another cause for prolonged bleeding after needle removal post-dialysis, which was outflow stenosis in the AV axis. And also central venous stenosis may be a cause of thrombosis of the AV axis because stagnation of blood secondary to stenosis. Finally, the patient may present by superior vena cava syndrome. Treatment of central venous stenosis. If it is asymptomatic, Piduki mentioned that it shouldn't be treated. If there is no clinical indicators and you discovered it accidentally, for example, the patient is doing imaging for any reason and you find that there is central venous stenosis, but actually there is no clinical indicators or symptoms, there is no swelling in the arm, there is no collaterals and so on, so it shouldn't be treated. But if it is symptomatic with clinical indicators, it must be treated. First, one of the treatment methods is axis ligation. Ligation of the AV axis may be the definitive treatment of central venous stenosis, but actually this sacrifices the axis. If there is thrombosis in the axis, use of anticoagulation, thrombosis secondary to the central venous stenosis, use anticoagulation with elevation of the upper extremity. But the more definitive therapy, especially if you want to save the axis of the patient, is balloon angioplasty. But actually the lesion tends to return. So a stent placement can be used with angioplasty combined with angioplasty in the following indications. However, stenosis may reoccur around the stent. Stent placement with balloon angioplasty can be indicated if the central vein lesion is elastic and easily distensible, or if dilated stenosis with balloon angioplasty recurs within 3 months. You did a balloon angioplasty, and within 3 months there was a recurrence of stenosis. It's better for the second time to put stent placement. Finally, subclavian vein stenosis can be relieved by axillary to internal jugular vein bypass. This is the end of our lecture and the end of our lectures discussing nephrotube synopsis of conventional hemodialysis first edition. I hope that these lectures were beneficial, and I hope that you liked it, and see you in I hope that there will be a coming book by me in another subspecialty in nephrology. See you in our coming lectures, inshallah.